I got a great question from a friend this morning. He asked me about his wife. She's done all the physical therapy and shockwave and regenerative therapy that she can, and now she is needing to get a diastasis repair. She has a 4-inch diastasis that just will not respond to anything that she's doing, including, significant core rehab, including pelvic floor physical therapy, shockwave therapy, and EMTT. And so she's tried all the regenerative tools. She has a 4-inch diastasis, and she has a hernia and persistent back pain. And she wants to get the surgery done to really solve her back pain once and for all so she can stop chasing this pain. So she's decided that a diastasis repair is the best fit for her. Now, they already have 5 children. They do not want to have any more children, but she is still fertile. She has not gone through menopause yet, probably in the perimenopausal phase. And the surgeon has suggested that to ensure that she never gets pregnant again, which they will not want to do after she has this abdominoplasty to repair the diastasis and the hernia, they suggested that she get a hysterectomy. And so he reached out to me and said, like, what is she at risk here of? And is this the best case scenario for us? And I came back to him and I was just like, here's the deal. If you need to do a procedure to stop fertility, the best case scenario is most likely going to be a tubal ligation if you really want to ensure that you're not fertile anymore, instead of removing the organ itself. I don't love removing the uterus itself, because even when you remove the uterus, your risk of prolapse, so either they leave the cervix or they remove the cervix entirely, your risk of prolapse is still pretty significant, because the uterus provides a good internal structure. It's taking up space within the abdominal, pelvic and abdominal cavity. And when you don't have that space taken up, then something's going to fill that space and you create an instability. So what we see postmenopausal, at least in the clinic, is that women in their 50s and 60s and 70s end up getting these vault prolapses, where after the hysterectomy, the vault that has been created to mimic the cervix and or the remaining cervix start to fall, because they don't have the integrity of the uterus and all the uterine ligaments that then are holding up the structure itself. And so you're at risk for more of a cervical, more uterine prolapse and or a vaginal vault prolapse. And it's really important to consider getting manual pelvic floor physical therapy done prior to the surgery to ensure that you open up the pelvic floor and make sure that you can manage your intra-abdominal pressure. So intra-abdominal pressure is when you inhale significantly and you increase the abdominal pressure, that's going to put more pressure downward on your pelvic floor and on the pelvic organs. Now, after any abdominal surgery, because of the swelling, because of the tightness that's created after an abdominoplasty or after a diastasis repair and hernia repair, because of that tension, you're going to also have tension in your pelvic floor. You're going to have increased abdominal pressure. So in order to help make sure that you can manage your intra-abdominal pressure, which is going to decrease your pain, but it's going to decrease the pressure down on the pelvic organs, helping reduce the risk of the pelvic organ prolapse, is to make sure that you have adequate eccentric elongation of the pelvic floor. That is how the pelvic floor opens. Now, if you don't have that eccentric elongation of the pelvic floor, you have tightness in the pelvic floor, that's going to increase the intra-abdominal pressure. So if you go into surgery with a really good elongation, even if you get tightened up during the surgery abdominally, which is always going to pull and create tension in the pelvic floor itself, creating more intra-abdominal pressure and predisposing you to pelvic organ prolapse, is you're going to want to make sure that you have that opening prior to surgery that will help your results post abdominoplasty or post diastasis repair. Another consideration is post diastasis repair and hernia surgery repair, you are going to want to manage and treat that scar tissue. So ensuring that you can treat that scar tissue. And having a tubal ligation also is going to lay down scar tissue. So no matter what, you're going to want to deal with the scar tissue that is caused by the tubal ligation, and that is also caused by the diastasis repair and hernia repair. Because if you don't address that scar tissue, then you're going to have deficits in your deep core musculature, and your musculature isn't going to be able to fully contract and fully relax. And then the tightness created by that scar is abdominally is also going to pull up on the pelvic floor, creating more tension inside the pelvic floor. The more tension we have, the more likelihood that we have to be predisposed to not only joint pain and a weak core, but also to be predisposed to pelvic organ prolapse. My friend's wife was also concerned about pelvic organ prolapse because her mom had had a pelvic organ prolapse. And one of the things that I was thinking as, a professional in the field and who's seen a ton of clients with diastasis is, if you have diastasis and you've had trouble recoiling your abdominal wall, there might be some underlying genetic collagen components to this and how your tissue restores. So if your collagen makeup is just more flexible and you have more laxity in general and not a ton of tight stability, and like that makes me think because she didn't get the abdominal recoil, she might have more of that laxity in general. She is going to be predisposed to having that pelvic organ prolapse because she might just have more laxity of all her ligaments that are holding up the pelvic organs. And so even more reason to get manual pelvic floor physical therapy so she could open up the pelvic floor and really create space so her organs have spaces to be. And so that any increase in intra-abdominal pressure that's going to happen because of the surgery won't put any of that downward force down on the pelvic organs. So these are some massive considerations. I'm kind of biased. I don't love the idea of removing organs. I had asked him, I was like, does your wife have like excessive bleeding? Does she have like excessive pain with menstruation? Because that's sometimes why people will, resort to hysterectomy, even though honestly, doing a lot of shockwave around the uterus is going to help prevent the heavy bleeds and prevent that any cramping or pain with menstruation. So just freeing up the uterus, allowing it to move better is going to solve that problem. However, so I just felt like that was a really, it was a really invasive recommendation just to manage fertility, was to like do the full-on hysterectomy. And no judgment. If they decide to do the full-on hysterectomy because they want zero absolute risk of any pregnancy, then, be it. But I said, absolutely leave at least 1 or 2 ovaries if possible, especially if there's no underlying malignancy worry. You want to leave the ovary so she can have some degree of natural regulation of her hormones. And so she doesn't just shoot into full-on menopause. So these were my considerations when thinking about, okay, I don't want to have any more babies. I'm going for this abdominal surgery. And the surgeon's literally saying, I am not allowed to get pregnant after I have this surgery. How do I prevent the pregnancy? And we're already in there anyways. Should I get the hysterectomy, or should I, is there something else to consider? And I just think the hysterectomy is going to be a lot more scar tissue, but I'll leave a lot of empty space, which has a tendency to, create a prolapse later on in life. And so, hands down, just some massive considerations when undergoing diastasis repair and hernia repair. So I hope this helps you. Leave comments below, like and subscribe to this video, share with all your friends that are considering getting an abdominoplasty, diastasis repair, or hernia repair. Okay, take care. I'm Dr. Allison.